Hospital, Parental Nutrition Consultation and Monitoring Service for Adults and Adolescents. Procedure and Process. Procedure. Responsibility of pharmacist. Obtain the names of patients receiving TPN in his/her patient care area of practice via an electronic health record (STEM) list. Estimate the patient's nutritional caloric needs using validated requirement calculation methods. Consider the patient's current nutrition status, disease states, clinical status, lab values, medications and fluids when initiating or adjusting a TPN. Pharmacist role for all following categories. Prior to initiating or adjusting TPN, the pharmacist will successfully pass a general TPN competency exam. Pharmacists will monitor fluid, electrolyte, acid-base status and blood glucose in patients using standard laboratory values. Pharmacist will leave a progress note if one of the criteria below is met, TPN being initiated, TPN formula is changed or modified, within 24 hours of patient transfer in level of care every 48 hours in the absence of criteria, B, or C above. Pharmacists will write orders for macronutrients and electrolytes per TPN guidelines listed in this policy. Changes to the amount of a macronutrient or electrolyte in a continuous TPN will be effective with the next continuous TPN bag to be hung at 2,200 daily unless the clinical condition requires these changes to be made sooner. Changes to the amount of macronutrient or electrolyte in a cyclic TPN will be effective the next cyclic TPN bag to be hung at 2,000 daily unless the clinical condition requires these changes to be made sooner. Pharmacists may order labs or procedures deemed necessary to provide optimal nutrition management including electrolytes, electrolyte protocols, renal and hepatic function tests, triglycerides, serum glucose checks, CRP, prealbumin and indirect calorimetry. Estimate energy requirements determine patient's weight, actual B6:5 weight in kg, ABU. The patient's actual body weight at hospital admission will be used for all energy requirements and protein requirement calculations except where specifically stated. Ideal body weight in kg, IBW. HAM-F. The patient's ideal body weight will be used in specific circumstances such as obesity, pregnancy, chronic hemodialysis as outlined. Male, 48 kg plus 2.7x, height in inches minus 60. Female, 45.5 kg plus 2.3x, height in inches minus 60. Obese equals BMI 30. Calculate AE/24 hours using validated energy requirement calculation methods relevant to patient's clinical condition. 3. Estimate stress factor, fluid volume. TPN should not be used to completely satisfy fluid requirements. Most TPNs infuse at a rate of 50 to 75 ml/hr. If additional fluid is required, physicians should order a maintenance fluid in addition to TPN. Assess need for fluid restriction, specifically CHF, renal failure, and concentrate TPN as able. Estimate protein requirements and support. Recommendations. Amino acids, 4 kcal/g. See Appendix B for estimated protein requirements in various patient populations and disease states. Prealbumin equals 2 to 3 days, is preferred over albumin as an indicator of nutritional status equals 20 days. Prealbumin will be checked a minimum of once weekly. C-reactive protein. Recommended if prealbumin does not trend upward in the absence of other clinical explanations. Monitor BUN and SCR and consider limiting protein when risk of nephrotoxicity is high, i.e., acute or chronic renal insufficiency. Specialized hepatic amino acid formulas, branched-chain amino acids, will be considered in patients with more than grade L hepatic encephalopathy. Consider checking nitrogen balance to monitor protein utilization, LGN2 equals 6.5 g protein, in appropriate patients. Estimate lipid requirements and support. Recommendations. Lipids, 9 kcal/g, to kcal/ml. Lipid bottle and tubing will be changed daily at 2200 hours for continuous TPN and 2000 hours for cyclic TPN unless otherwise specified by a physician or pharmacist. The maximum hang time for each lipid bottle is 24 hours. Optimal dose, 25 to 30% of total kcal. Required minimum of 4 to 10% of total kcal to prevent essential fatty acid deficiency, EFAD. Baseline and weekly triglyceride, TG, level will be monitored and should remain 400, give 500 kcal, 250 ml, of lipid once or twice weekly to prevent EFAD. Monitor TG at least twice weekly in this patient population. For patients receiving propofol, lipids may be held or the rate adjusted as deemed appropriate by the pharmacist. Triglycerides will be monitored to determine need for adjustments. Starting or only it's due to concurrent use of ROFO. Dextrose will provide the balance of required glucose not provided by routine and lipids. 2. Dextrose should provide approx 50 to 60% of total glucose, 2 to 5 g per kilogram per minute. 3. Maximum concentration of dextrose will be 10% peripherally and 5% centrally. 4. The time of TPN initiation. If the patient is not currently on all active dose insulin or an insulin infusion protocol and does not have a hospitalist or intensivist currently consulted, the standard scale dose is as follows. Blood glucose adult insulin, 300x2, more than 355 units in call a physician. Dextrose, 3.4 kcal/5. Further adjustments to insulin orders will be made via HCSIN. 6. If 2 consecutive blood glucose levels are $150 mg/2, the pharmacist will notify the physician and recommend a hospitalist consult for management of hyperglycemia. Pharmacists will also decrease dextrose in the TPN formulation as able to minimize further risk. 7. The time of TPN initiation. If the patient does have current insulin orders or a hospitalist or intensivist consult, the pharmacist will notify the physician of the TPN initiation so he/she can review and adjust the insulin orders as needed. 8. Calculate non-protein kcal:-nitrogen ratio, NPK:(N2), to determine if here is adequate kcal necessary for proper protein utilization. Recommended NPK:(N2) for maintenance equals 150, 1, mild to moderate, stress equals 90, 120 to 1, severe stress/critical, illness equals 70,100, 1. Electrolytes, sodium, Na, normal serum, value, 135 to 145 standard amount in TPN is 3280 mg per liter, 1/2 NS equals 77 mg per liter. Pharmacists will initiate TPN with standard Na unless physician or disease state requires otherwise. Hyponatremia. Pharmacist will consider fluid status and disease states in patients with mild to moderate hyponatremia, Na 125 to 135. If patient is fluid overloaded, no adjustments will be made. If patient is determined to be in normal fluid balance and 2 consecutive Na levels are low, pharmacist may increase Na in next TPN. Hypernatremia. Pharmacist will consider fluid status of the patient and reduce Na in next TPN as appropriate. Pharmacist will consider using a low-sodium amino acid formulation to minimize Na content of TPN as appropriate. Potassium, K. Normal serum value, 3.5 minus 5.1 standard amount in TPN is 30 to 40 mg per liter. Pharmacist will initiate TPN with standard K unless physician or disease state requires otherwise. Hypokalemia. K replacement protocol will be ordered at the initiation of TPN for all patients with the exception of dialysis patients. K in TPN will be increased per pharmacist discretion based on lab value, diuretic use, other 4 fluids, and total K replaced per protocol. Hyperkalemia. 1. For K more than 6 or symptomatic hyperkalemia, TPN rate will be reduced or stopped. If TPN contains K, and pharmacist will adjust amount of K in next TPN per his/her discretion. Magnesium, mg. Normal serum value, 1.8 minus 2.6. Standard amount in TPN is 4 to 12 mg per liter. Pharmacist will initiate TPN with standard mg unless physician and/or disease state requires otherwise. Hypomagnesemia, mg replacement protocol will be ordered at the initiation of TPN for all patients with the exception of dialysis patients. mg and TPN will be increased per pharmacist discretion based on lab value and total mg replaced per protocol. Hypermagnesemia, 1. If patient experiences symptomatic hypermagnesemia, TPN rate will be reduced or stopped. If TPN contains mg, and pharmacist will adjust amount of mg in next TPN per his/her discretion. Calcium, Ca. Normal serum value, 8.5 10.5 mg/2. Ionized calcium. Normal serum value, 1.19 minus 1.3 mol per liter. Standard amount in TPN is 5 to 10 mg per liter. Pharmacist will initiate TPN with standard Ca unless physician and/or disease state requires otherwise. To minimize risk of precipitate formation in TPN solution, Ca, mg per liter, plus Phos, mol per liter, 45. To minimize risk of precipitate formation in soft tissues, Ca, mg/2, x Phos, mol per liter, 60. Hypocalcemia. Pharmacist will consider patient's serum albumin and may order ionized Ca prior to increasing Ca in next bag of TPN. Ca and TPN will be increased per pharmacist discretion based on lab value and any replacement doses given. Hypercalcemia. If patient experiences symptomatic hypercalcemia, TPN rate will be reduced or stopped. If TPN contains Ca, and pharmacist will adjust amount of Ca in next TPN or his/her discretion. Phosphorus, Phos. Normal serum value, 2.4 minus 4.7 mmol. Standard amount in TPN is 10 to 15 mol per liter. Pharmacists will initiate TPN with standard Phos unless physician and/or disease state requires otherwise. To minimize risk of precipitate formation in TPN solution, Ca, mg per liter, plus Phos, mol per liter, 45. To minimize risk of precipitate formation in soft tissues, Ca, mg/2, x Phos, mol per liter, 60. Hypophosphatemia. Phos replacement protocol will be ordered at the initiation of TPN for all patients with the exception of dialysis patients. Phos and TPN will be increased per pharmacist's discretion based on lab value and total Phos replaced per protocol. Hyperphosphatemia, 1. Pharmacist will decrease Phos in next TPN per his/her discretion. 2. Note that lipid formulas contain phosphorus 3, so patient may continue to receive some phosphorus even if it is removed from TPN. Both 10% and 20% lipid emulsions, i.e. propofol and liposin 1110, contain 15.5 mol of phosphorus per liter. Chloride and acetate. Bicarbonate. Normal serum values, C, 98 110 mg per liter. Bicarbonate, 22-32 mg per liter. Standard acetate chloride ratio in TPN is 1:1. Metabolic acidosis. If severe, pharmacist should minimize chloride in TPN. If mild/moderate, the ratio may be adjusted per pharmacist's discretion. Metabolic alkalosis. If severe, pharmacist should minimize acetate in TPN. If mild/moderate, the ratio may be adjusted per pharmacist's discretion. Multivitamin. Pharmacist will order standard multivitamin with vitamin K unless otherwise specified by the physician. See Appendix C for ingredients. Patients receiving anticoagulation with warfarin may remain on multivitamin with vitamin K with careful monitoring of INR or CFX values. Trace elements. Pharmacist will order standard trace elements unless otherwise specified by the physician. See Appendix C for ingredients. Disease states where certain elements will be removed. Renal dysfunction, SCR more than 2 to 3 unless patient is receiving dialysis. Consider removal of selenium and chromium if on long-term TPN, 10 plus days, due to risk of accumulation. Hyperbilirubinemia, TBL more than 3 to 4. Consider removal of copper and manganese if on long-term TPN, 10 plus days, due to risk of accumulation. Additional supplementation. No additional additives other than the standard multivitamin and trace elements as stated above will be added to any TPN formulation except those specifically stated in this section. Vitamin C. Patient population. Wound healing of surgical incisions or stage 2 or greater pressure ulcers may benefit from vitamin C supplementation. Pharmacists may add ascorbic acid 500 to 1,000 mg/day to TPN. Patients with renal insufficiency who are not receiving dialysis will receive a maximum of 500 mg/day. Patients with a history of or at risk for nephrolithiasis will not receive additional ascorbic acid. Zinc. Patient population. Wound healing of surgical incisions or pressure ulcers may benefit from zinc supplementation. A. Pharmacists may add zinc 5 to 10 mg/day to TPN. Patient population. Patients with significant stool and or GL fluid loss from diarrhea, ostomies, fistulas, etc., are at risk of deficient and may benefit from supplementation. Pharmacists may add zinc 5 to 10 mg/day to TPN. Patient population. Patients who receive propofol infusion for more than 5 days are at risk of deficiency due to the chelating effects of EDTA. Pharmacists may add zinc 5 mg/day to TPN. If a patient has more than one of the above indications for zinc supplementation, a maximum of 10 mg/day will be added to TPN. Insulin. Insulin may be added to the TPN bag at the physician's discretion after the TPN infusion has been at goal rate for at least 24 hours. Physicians will be responsible for making all insulin dose adjustments. Initiation of insulin and dose adjustments will be communicated to the pharmacist either verbally or via TPN changes from provider to pharmacy. For any TPN containing insulin, all changes made by pharmacy to the dextrose concentration will be communicated to the physician. Then any TPN containing insulin is discontinued. Pharmacy will contact the physician for new insulin orders if not already addressed. Osmolarity. For peripheral line, total osmolarity for peripheral TPN must be 900 mosm per liter to prevent phlebitis. Osmolarity of substrates and additives. Amino acids. 100 mosm/gm%, e.g. 4% AA contributes 400 mosm per liter. Dextrose, 50 mosm/gm%, e.g. 8% dextrose contributes 400 mosm per liter. Electrolytes, 1 mosm/mec, e.g. 20 mec of K contributes 20 mosm per liter. Lipids, isoosmolar, can be given peripherally or centrally. Administration rate. In general, TPN will be initiated at 1/2 goal rate for 24 hours and then increased to goal rate. In patients deemed to be at risk for refeeding syndrome, the TPN will be initiated at a maximum of 1/2 goal rate for a minimum of 24 hours and then increased to goal rate per pharmacist discretion. The maximum hang time for all TPN bags is 36 hours. In patients recently on TPN or changing from continuous to cyclic TPN, the titration to goal rate may be accelerated per pharmacist discretion. If TPN is to be discontinued, cut TPN rate in half for 2 to 4 hours and then discontinue or per physician recommendations. Lipids do not need to be tapered when discontinuing.